My name is Jessica Young. I'm an assistant professor at Vanderbilt in the OBGYN department. I'm a generalist obstetrician and gynecologist, and I run our obstetric drug dependency clinic where we treat primarily opioid dependent pregnant women. And we started this clinic 4 years ago with the goal of integrating prenatal care with addiction therapy. And so I have my buprenorphine waiver, and so I'm able to prescribe buprenorphine maintenance for my patients. And we collaborate with our inpatient teams, both with psychiatry and obstetrics, and many of the women in our program have gone through an inpatient stabilization transition to maintenance therapy, detox off of benzodiazepines and other harmful substances that they can't continue, and then follow up outpatient with us for continued prenatal care and treatment. I think it's really important when we're talking about this issue to understand the medical reasons and evidence that we do what we do in pregnancy. It's really important to understand the risks of opioid use and abuse and dependence in pregnancy, and also to understand what is evidence-based about treating addiction in pregnancy. I think fundamentally we have to remember that addiction is a medical and psychiatric disorder. Addiction can lead to illegal behavior, but the addiction itself is a medical disorder and needs to be treated, and psychiatric disorder, and needs to be treated as such with the appropriate resources. Another important thing to remember in this population is in many studies, over 90% of these pregnancies in this population are unintended. And that is an area that we could do much better with targeting. Of course, that doesn't mean these pregnancies are undesired, but these people who are struggling with addiction didn't go out and plan to get pregnant at this point in their lives, typically. The standard of care, as other people have said, during pregnancy is maintenance-assisted therapy, and there are several reasons for that. One of the reasons is that the risk of relapse during pregnancy is very high, and if you completely detox a pregnant woman without the appropriate resources in place, then you are putting her and at risk for relapse and all the complications of relapse. The other reasons that maintenance therapy is the standard of care is that we know that outcomes improve for women who are on maintenance therapy. We see better compliance with prenatal care, we see better birth weights, less IUGR, and better outcomes and better engagement in their addiction recovery. For decades, methadone maintenance has been the standard of care and is what really all other treatments are compared to. The issue with methadone is availability. In the Middle Tennessee area, there are 2 licensed methadone treatment facilities, and methadone treatment facilities for addiction require a daily visit to the clinic. And you go to the clinic every day and you get your dose. So you can imagine if you have to drive 30 minutes, an hour, 2 hours to your closest methadone treatment facility, that's not really a viable option for most people, particularly when for many of the patients I see, transportation is an issue to begin with. For those of my patients that have jobs, it also makes it very difficult for them to go to a methadone treatment facility and to incorporate that into their daily routine. Most methadone clinics do not take insurance, so this is an out-of-pocket cost and expense, which can vary between $70 to $100 a week, so that's a big out-of-pocket expense. And as what has been mentioned before, the neonatal abstinence syndrome risk is not eliminated. The risk on methadone maintenance is about 50 to 60%, depending on what study you look at. The other option, which is a newer option, which we really have almost primarily switched to at Vanderbilt, is buprenorphine maintenance. And one of the reasons that we've switched to it is because of the lack of access to methadone treatment. So with buprenorphine, that is a medicine that physicians can prescribe if they have a waiver to prescribe it. So that means you've gone through a standardized training program and applied for a waiver. And so patients get prescribed a pill that they take every day. And buprenorphine has an agonist and an antagonist quality, so it stimulates and blocks the opioid receptors in a different way than methadone. So it's not really a true opiate, although it does act on the opiate receptors. So many women will tell you that on buprenorphine they feel normal, and if they're on the right dose, they really should feel normal rather than intoxicated or high. The barriers to buprenorphine are that there is a limited number of providers who have their waiver. There are definitely insurance limitations in that with our state Medicaid, they will not pay for a dose over 16 milligrams. And there are women, especially with a history of IV drug use, who require 24 or more milligrams to remain stable. And we know that the neonatal abstinence syndrome rates are probably about 45% for women who are using buprenorphine. And anecdotally, our pediatricians, our neonatologists at Vanderbilt tell us they prefer to have a baby who's exposed to buprenorphine rather a baby who was exposed to methadone. And in the study that was the mother trial that was done at Vanderbilt and Baltimore and all over and several other places showed that buprenorphine was just as safe as methadone in that study, and babies had slightly less or slightly shorter stays in the neonatal intensive care unit if they had to be treated for NAS, and the withdrawal symptoms tended to be less severe, so they tend to require less medication if they're being treated for withdrawal. Of course, maintenance-assisted therapy alone is not enough to treat addiction or opiate addiction. The mental health treatment and component is extremely important. So it's extremely important that patients are engaged in counseling and treatment of co-occurrent psychiatric disorders. In many studies, 60 to 80% of women have a coexisting psychiatric disorder, anxiety, depression, PTSD, bipolar disorder, and my clinic population, it's much higher. It's probably more around the lines of 90% of people have a coexisting psychiatric mental illness. And what we see is that often, if they stop their psychiatric medications due to insurance issues or not having access to a psychiatrist to prescribe their medication, they often relapse at that point. We see that all too frequently. At Vanderbilt, for women who present in acute crisis to the emergency department seeking treatment that are pregnant, they're generally admitted for stabilization for 3 to 7 days, kind of depending on what they've been using and how well they stabilize on the maintenance therapy. We will occasionally detox women completely, but that tends to be not in an acute setting, but someone who a treatment provider has worked with very closely in an outpatient setting, they're very stable, and then we bring them inpatient to detox completely. But that's definitely the exception rather than the rule. The issue for inpatient stabilization is what happens once they're discharged. And I think the struggle that we face and what we see is most of these women end up returning to the communities that they came from, and often in those communities they're surrounded by people that are using and abusing the same substances the woman is seeking treatment for, and that makes it difficult for someone to really remain engaged in a treatment program. Waiting lists for the residential rehab programs in our state, as we've heard, can be very long, and often there aren't spaces available when they are needed. I find also in talking to my patients that there's a lot of pressure for them not to be on maintenance-assisted therapy, despite that being the medical standard of care. They get that pressure from their families, from their communities, from DCS workers, and actually sometimes from other addiction programs, because there is a stigma to being on maintenance-assisted therapy. There are segments of the addiction treatment community who feel like maintenance-assisted therapy is not real sobriety, and we could argue that for back and forth. But it is difficult for patients when they're hearing and getting pressure from lots of other resources, because data evidence often doesn't ring as true as your mother, your cousin, your friend sitting next to you and telling you that you should just stop what you're doing, and that would be ultimately better. And that's what these patients hear. Why can't you just stop? Why can't you just stop? And I think it really indicates a lack of understanding of the problem and the condition of opiate dependence. And what I'm often asked is, what about detox? Why can't we completely, or get these people completely off these medications that are associated with neonatal abstinence syndrome, which we all would like to prevent and not see? I think and there are some studies that show that you can safely detox women completely from opiates during pregnancy. However, those studies show that those women that are successful and remain in sobriety throughout their pregnancy, their rates of neonatal abstinence syndrome are very low, in the 5% or so range, which is great. However, in many of these studies, 50 to 53% of the people who get detoxed relapse and go back to using, or realize it's too hard and opt to go to a maintenance-assisted therapy program, or have such severe withdrawal symptoms during their detox that they deliver. So it's a complicated issue without an easy solution, and we definitely need more research in this area. But I would say fundamentally, the problem, at least we have in Tennessee with complete detox, is we don't have the resources to support these women once they're completely detoxed. You can detox anyone, but if you send them back to their community where they have the same stressors, the same trauma, the same exposures, you're just setting them up for failure, which I think is not medically or morally right. Anyway, I think we have time for questions. I'm happy to